Good afternoon. Thank you for joining us. I'm Kate Breslin, President and CEO of the Schuyler Center for Analysis and Advocacy. We are a nonprofit, statewide organization based in Albany, New York, that focuses on shaping policy that affects the most vulnerable New Yorkers. If you're new to our organization, be sure to stay in touch via Facebook. So like us on Facebook and stay in touch. Today's event is a conversation with New York State's Medicaid Director, Jason Helgerson, on the first 1,000 days on Medicaid initiative. A few notes before we get started. For materials on today's program, visit our website, scaany.org, scaany.org. There's a Facebook Live button on the home page that will take you to a page that contains slides that Jason Helgerson developed, links, and information about the initiative. If you have questions today, send them at any time to info@scaany.org. So we are eager to take your questions during this 1-hour Facebook Live conversation. And again, send your questions via email to info@scaany.org. So Jason Helgerson is with us today. I'd like to tell you a little bit about Jason Helgerson. He became New York's Medicaid Director in 2011. New York's Medicaid program provides vital healthcare services to over 6.2 million New Yorkers and has an annual budget in excess of $60 billion. Jason also serves as the Executive Director of New York's Medicaid Redesign Team. In this capacity, he leads Governor Cuomo's efforts to fundamentally reshape Medicaid in order to both lower costs and improve care. In 2015, Jason was recognized as Public Official of the Year by Governing Magazine. Thank you for joining us today, Jason.
It's great to be here.
Can you give us an introduction to the first 1,000 Days initiative?
Sure. So we were very excited last summer, it was July of last year, to announce an opportunity for sort of the collective group of stakeholders who care a lot about children in New York State to sort of come together in an initiative and develop a 10-point action plan for improving outcomes for children on the Medicaid program. And we thought it was important for a couple of reasons. One, a lot of our Medicaid redesign efforts to date had really been focused on the populations where we spend the most money. Those tend to be adults, both with and without physical disabilities. And while we've done a lot to improve outcomes and also to try to make the program more affordable for taxpayers, we felt like we hadn't really done enough in terms of focusing on the needs of children in the community. But then also, I think that the statistics that talk about the role the Medicaid program plays, particularly in the lives of New York's youngest children, the statistics are pretty compelling that we have really an outsized responsibility relative to trying to improve outcomes for children in those first years of life. 59% of children under the age of 3 spend at least a part of those first 3 years of life on the Medicaid program. Over 50% of the children born in New York State are born when their mother's on the Medicaid program. So we have such a major impact on children across the state during those very formative years. And we know 85% of brain development happens in the first 3 years of life. So we really felt there was a need for a major initiative. And we're so excited that here we are after months of a very robust stakeholder engagement process to have a 10-point plan that we're able to move forward with.
Those of us who are in the child advocacy and child serving community really have been thrilled with the announcement of the initiative and also its sort of intentional work to engage sectors outside of health. And we know that the health sector is a really important touch point for our youngest kids since, as you said, so many of them are covered by Medicaid, so many of them have coverage, and most do see a doctor in their early years. But we also know that so many other systems are important. And so I'm eager to hear you talk a bit about the cross-sectoral nature. And as I said, we've been thrilled with the engagement of former Chancellor Zimpher and Commissioner Elia, and would love to hear kind of your thinking about that.
Sure. I think what we acknowledge full well is that in order to address the challenges faced by families and very young children in our state, we had to work cross-sector. Medicaid, the healthcare system, does play an important role, and in fact, if we do anything well in the Medicaid program, one of the things we do well is we do help to make sure that children get in to see their pediatrician, on a very, very frequent basis during those early years. Over 90% of children go in their first few months after they're born to see a pediatrician, and that's a very powerful touch point in the sense it's an opportunity to sort of help in the development of that child and support the family and identify issues early on that can be addressed much more effectively than if they aren't identified and they are allowed to worsen over time. But that said, we are but one system that touches the families, touches these children, and that's what I felt very strongly we had to work cross-sector. And we're so pleased in this effort to have Chancellor Nancy Zimpher, who's been such a long-standing advocate for cross-sector partnerships, helped create a national movement in this area, to be one of our co-chairs along with Commissioner Elia, to bring in very much into the effort the K-12 system in our state, which obviously is such a key role in children, in their development, their education, but also play a key role in those first 3 years of life as well. And so we really felt it was important to work cross-sector, because if we're going to be successful, we need cross-sector collaboration in communities all across the state. And
we're starting to see, to that recognition that if we do well in those first 1,000 days, that maybe we'll see better outcomes as kids enter and move on in school. So we'll really see the outcomes in other places. What are you thinking around next steps? And can you talk a little bit about, so we've now come up and voted on the 10-point plan. And I'd love to hear your thinking about how we got there, but also next steps for the 10-point plan. And as a reminder to folks who are watching and listening, we have links to all of this information on our website at scaany.org.
Sure. So in terms of the 10-point plan, one of the things that we brought out of this was, in essence, an early win. We knew this was going to be a diverse group of people from a lot of different sectors, and sometimes efforts of this size, there are 200 people on our work group, that sometimes these efforts can get bogged down and little is accomplished. And so we wanted, that's why I think part of our reason around the 10-point plan was to really have an opportunity for us to focus in on a subset of things. Not that it is certainly not the full universe of what we can and should do to improve outcomes for children during these first 1,000 days, but I think we just felt that at the end of the day, we needed something that we could move forward with, something that we could show accomplishments, so we could actually create some momentum for these cross-sector collaborations. Problems like school readiness are a problem because no single system is responsible, and it is extremely complex. If we are going to move the needle in that across this large and diverse state, we are going to need a meaningful collaboration, and I think meaningful collaboration needs to be built on trust. It needs to be built on a sense of possibility and a chance that these efforts, while hard, can in fact achieve success. And that's, I think, one of the core objectives of this sort of first stage of first 1,000 days was to be able to demonstrate success and implement these 10 ideas. And that's where we are now, is beginning to move into the phase of trying to develop an action plan from implementation. Some of them do have budgetary impacts, so we have to see from a budgetary standpoint how many of these we could potentially move forward with within the budgetary context. But others, and that's why I think it's what's great about our 10-point plan, is other items don't actually require new investments or things that we can immediately move to implementation phase while we see how the budget sort of plays out. But in terms of next steps beyond this, we're beginning to think about what we can do to keep this group engaged. This group was built out of a group established around value-based payment, but given the level of dialogue, discussion, interest in the group, we definitely want to keep it going. One of the ideas that we have is to see if we could maybe spawn similar efforts in communities across the state, because one of the things that we're interested in is local collaborations. There's a really successful local collaboration here in Albany called the Albany Promise. There are other efforts in Rochester and other parts of the state as well. And we'd like to sort of inspire more of those cross-sector collaborations to focus on the needs of children, particularly children in their first 1,000 days.
That's exciting. Yeah. So can you talk a little bit about how the work in Albany sort of helped to inspire you around this effort?
Sure. So we got approached by the Albany Promise around joining their collaborative that, in fact, had been engaged for several years. And they actually had done some analysis looking at school readiness and had done a lot of work around expanding four-year-old kindergarten and also even pre-K programs, with the idea being that pre-K would be sort of the solution for increasing the number of children that were entering the school system ready to learn. But what they were finding in terms of, as they engaged particularly those pre-K providers who are serving 3-year-old children, what they were finding was many of those programs were finding children coming to them developmentally behind where they should be. And they were already in these pre-K programs in a remediation phase and trying to address it, which is very challenging and frankly expensive, especially ultimately when those challenges reach the public school system in the form of special education. And so it led them to realize that there really is a lot that isn't happening that needs to happen in the Albany area around trying to identify those needs and issues even earlier than the case. And they were the ones who really did some of the initial analysis to look and see what were the most frequent touch points within different systems. And they really found that pediatric care, those first visits to see a pediatrician after a child's born, really was potentially a very powerful touch point in the system for identifying issues, making referrals to services like EI to begin to get children the care and services that they need. So they brought to us a proposal for how could we sort of maybe using our purchasing power and our contracts with managed care organizations to sort of bring those parties to the table to be part of it. We then brought with that the lens of value-based payments, with the concept being, and I think this is what is unique to the nation, is the idea that we're going to actually pay pediatricians more ultimately in this initiative when children who are in their care enter school in larger numbers ready to learn. And that is crossing a Rubicon from a value-based payment context to really say that it's no longer enough to make sure kids are immunized, it's no longer enough to make sure that screenings are conducted, but actually at the end of the day, we think that pediatricians and other stakeholders in the community have a responsibility to help really do things that meaningfully move the needle into such a key metric to society, which is school readiness.
Thank you. I'm going to ask my team to share with me if there are any questions, since I don't see any on my screen. So if people have questions, please feel free to email us at info@scaany.org, and we'll try and get to your questions. I want to follow up on something that you just mentioned that I think was really important for those of us who work in the health field and work on children's issues, that we really went into this initiative where much of the state's efforts have been around saving money and controlling costs. We went into this initiative with the understanding from everyone that we may have to spend more now on young children in order to generate better outcomes and better health later, and savings later. And I also appreciated that throughout this initiative, we really focused on evidence-based practices. So where do we find the evidence? And also the importance of parents and caregivers, because in our medical field, we often are thinking of individual patients. And there was a recognition from your agency and the partners at the table that it was really important that we think about children sort of in the context of their environment. So thank you for that. Okay. Do folks have any questions? don't see them. Questions. Your questions appear here. So if you want to write them down for me, that would be helpful. Or call them out. Bridget?
People want to know about the composition of the work group and how people use it.
Oh, sure. So we have one question about the composition of the first 1,000 days work group, which was very large.
Yes.
And
so
please.
As I mentioned, one of our starting point for this was the Children's Value-Based Payment Work Group, which Kate was kind enough to chair, and so that was a starting point. We brought together a number of different child advocates, providers, or experts in early childhood development for that particular work group, which worked on both policy issues as well as played the role of what we call a clinical advisory group, which is really to design, help us design the various value-based payment models, including selection of measures. And so that was our starting point for the group, but then we basically looked to expand the membership, and in fact left the membership wide open. We put no limits on it, and that's how part of the reason we got to 200 individuals participating from all across the state, which we think overall was great. It was also part of the reason why we decided to use a voting process that actually had been used earlier in the Medicaid redesign team efforts as a way to help collect preferences from this large and diverse group. We wanted the entire collective view of the group to be reflected in the final outcomes and or the final product. This first phase, and so we felt that at the end of the day that it was a robust membership, some really smart, dedicated people who took a lot of time out of their day jobs to come to Albany or to New York City to attend meetings and provide us with a lot of very important feedback. So we feel always open to additional interest. We never closed the work group. We're not going to close it now. So we always want to try to, we're a big diverse state, we want to be able to tap into all the expertise that exists.
And I appreciate that we did the meetings both in New York City and Albany, and we also had phone access for folks, and even when it was sometimes hard to do that with over 100 people at a time, we were always really open to people's comments. And we had also, in addition to amazing leadership from the Chancellor and the Commissioner and my co-vice chair, Jeff Kazarowski, the United Hospital Fund did a amazing job.
Yeah, I think Chad Shear and Suzanne Brundage deserve tremendous credit. I mean,
absolutely.
Behind the scenes, they're the ones who did a tremendous amount of work on this, and particularly Suzanne, I know, who really, did a lot of the work herself, helping prepare the policy papers and the PowerPoint slides.
Yeah.
I think it was an extremely well-staffed initiative, and they really made a huge difference in terms of that, because they were the ones who did so much of the work. And so we're so appreciative, because in these times, agencies are a little stretched for resources, and they stepped up and have been tremendous partners.
Yeah, and I think it was really interesting for me. We had a lot of folks who, people are good at talking about what the problem is with the system, but when you are asking people to come up with tangible suggestions, implementable,
yep.
I think that's really the hard part. And I want to credit the work group and the United Hospital Fund staff and your agency and others in other agencies. So there, we have people from the Office of Mental Health, Office of Alcohol and Substance Abuse, Office of Children and Family Services, all sort of trying to come up with those tangible, actionable solutions.
Absolutely. And the other thing I would say too is that sometimes the natural inclination in this process, in an effort like this, is to want to simply propose new things. But I do think that what this group did was, while it acknowledged that there are holes in the system, there are things that can and should be done to enhance services for children in their first 1,000 days. there are also things that exist today that are not performing as well as need to be. And we need to carve out time and resources for addressing those, structural problems, and acknowledge the fact that not every program that we've created over the years that is working and achieving the goals that it should. And I compliment the group on when we coalesce around it, is that there are clearly things that we can and should do to improve existing initiatives so that we can maximize the return for children and families.
Yep. Yep. Now, you touched on this a little bit as you opened, but we have a question about why Medicaid. Why Medicaid should play such an important role in the first 1,000 days. So if you could just talk about that.
Sure. I mean, as I said, the statistics are pretty clear. 59% of kids in New York under the age of 3 spend at least a portion of their lives those first 3 years on the Medicaid program. 50% of all children born in the state are on the Medicaid program, or their mothers on the Medicaid program at the time of their birth. There's, and just a tremendous role and responsibility, I think, when, over half of the children in our state are benefiting or relying on a program. And as I said, 85% of the brain development occurs in those 3 years. And while it's not purely a healthcare objective, things like school readiness, the healthcare system plays a key role. And I think that what we're trying to do here, and hopefully we inspire other sectors as well, to begin to embrace this, is that something like school readiness is such a major predictor of lifetime success. And I think each sector needs to say, and when I say sector, I mean K-12 education, higher education, criminal justice, all of the sort of social services that are out there, our libraries, our local governments. If we all sort of embrace the challenge of trying to improve a metric like school readiness, and think about what is in our power, purview, how to what things could we change, improve, enhance, as well as what can we do in collaboration with these other sectors. I think it's, the possibilities are tremendous, and I think there's tremendous untapped potential out there in terms of what these local collaborations could do.
Can you talk a little bit more about what you think the levers are to enhance local collaborations?
Sure. So in fact, one of the things that we're going to be looking at, of the recommendations, are a number that suggest pilot programs. So one of the things that we're going to do as we think about pilot programs in communities across the state is to say to the communities, if you want to be a partner, if you want to receive funding from the state, we are going to expect you to come forward as a collaborative. So if there's a table that already exists where organizations are working, come through that vehicle to apply for funding. Or if your community doesn't yet have that kind of collaboration, create it as part of this initiative. We definitely want to leverage the investments that we make to bring that collaboration, because we know firsthand experience in our Albany Promise project here that without the infrastructure, it would be extremely difficult for the Medicaid program to really feel like it's having the kind of impact. This requires change agents on the ground in these communities. It requires a backbone and a commitment to at least staffing the initiative adequately to help make sure that it's successful. Collaborations, organizations coming together, that doesn't just sort of tend to happen on its own, and it's hard work, and we want communities to begin to commit human capital resource to the effort, and it can be done, and Albany's one example, Rochester is another, where those kind of collaborations are happening, and we want to use this as an opportunity to inspire more.
Great, great. So I know this will probably not come as a surprise, but there's a question about the Children's Health Insurance Program.
Yes. And
there's been a lot of worry in the last couple of months because, as many of you who are listening and watching know, Congress failed to reauthorize CHIP, and CHIP expired on October 1st of this year. So there's great concern about the funding, most of which is federal, for the CHIP program. And I think the question here is about CHIP, but I know we all know there's some uncertainty in general around the commitment from our federal partners. So if you could talk a little bit about this work in that context.
Yes, I mean, what's really unfortunate is we've gotten to the point where Washington dysfunction really is getting closer and closer to having a meaningful impact in New York State. And, as Governor Cuomo has said, while we have been monitoring, and to some extent, particularly around the Affordable Care Act, we had some success in sort of fending off some very draconian things. some of the dysfunction has led to us getting to the precipice of some pretty bad things. And one of those is CHIP reauthorization and the fact that while the Congress took an action to provide a small increment of additional funding, all states, including New York, are getting closer and closer to the point where we're going to run out of money for that program. And I was just seeing that another state today sent out letters to parents notifying them that effective within the next couple of months, that the program in that state could very well come to an end.
At a time when families should be opening holiday greetings.
Greetings,
right?
yes. Quite the Christmas holiday present to receive is a letter saying that your child's health insurance is going to be taken away from them. And that's unfortunately the reality that we have in the United States today. And I think right now the biggest challenge we have in New York is the dysfunction and coming from Washington. And and for those of us who worked on the Affordable Care Act, and those of us who have been spending a lot of time on these issues in New York State for the past 8 years or so, we had a very strong partner in Washington who worked with us around both our healthcare access and expansion efforts, as well as delivery system reforms. A very active partnership there. That partnership really has left the station. And my hope is that on CHIP that cooler heads eventually will prevail, and we'll get an extension of the program. How long that extension is, I think it's an open question. I think it's looking more and more likely that it's going to be a shorter-term extension, and every few months we could be once again having to fight for what used to be a clear bipartisan priority, which is health care for children.
Yeah. Especially when, as you've referenced, every day counts. Every first 1,000, every single day counts for kids. It's astonishing.
Yeah, we're the only Western or developed nation in the world where this debate actually happens. And we're the only developed nation in the world where people are talking about taking health care away from them. But that is the world in which we live. I think our politics on this are completely backwards.
Yeah. Well, thank you for speaking out about that. Yeah. You've been pretty.
So it's unfortunate, but we just have to continue to advocate. And as I say, we hope that cooler heads.
So could you? One of the recommendations was about an inventory, a kindergarten skills inventory. That is certainly one of the kind of, I guess I would say, cross-sector recommendations. Can you talk a little bit about your perspective on the likelihood of that happening and thoughts on what are the best ways to see that happen?
Sure. So the good news about our effort is it's pretty well timed, in the sense that it's been following or at the same time a parallel effort that's been led by our colleagues at the State Education Department. And what they've been looking at early childhood as well, and they've been looking to see what they can do. And I think there's a growing consensus around the need to really effectively assess the needs of children, particularly when they come into the public school system, in terms of their readiness and effectiveness, as well as in our side, through the developmental screens that are done by pediatricians to make sure that we're identifying needs early. And I think that there's a need for us to work together. I think that growing consensus, I hope, eventually leads to a situation where we have a standard assessment of school readiness. Other states do. I think it is one of the most, as I said, powerful predictors of a child's success in life. But yet we still, to this day, lack that assessment. It's not a high-stakes test. It's really meant to identify the needs of a child so that we can better meet those needs. And what it then would do is would allow us to also do what we're trying to do here in Albany, which is to do a standard screen for developmental status, collect that data across the entire county for literally all children. So we literally know exactly what the developmental status is of every child at the age of 3, which would be very, very powerful data and information that will allow us to really begin to hone strategies towards improving developmental status, which I think at the end of the day is got to be where we focus resources.
And it's exciting to hear our Medicaid director talking about the importance of school readiness, and I want to just reflect on at one of the meetings, one of our best loved regions, Jim Talon was at one of our early meetings as head of United Hospital Fund and really said the same thing. You know, wow, this is to hear our Medicaid director talking about the importance of school readiness is something that, you know, many of us sort of in the early childhood field have thought for a long time and waited for. So thank you for talking about that. And as you said, school entry, readiness at entry is a great predictor. It's also a great proxy for how well we've been doing in the early years. It's a great way of knowing how healthy, in the large sense of the word, how healthy well our kids are.
Absolutely.
Yeah.
And I think at the end of the day, I say sometimes about social determinants of health is that it's on the part of the healthcare system, we can be a little selfish in the sense that it's typically put in the context of, can we invite the human service sector? Can we invite the K-12 system? Can we invite criminal justice to the table to support us in our efforts to achieve our metrics, to achieve savings in our system? And that's what we typically talk about in terms of social determinants, which is basically asking those sectors to embrace our measures. But rarely do we in the healthcare sector say, you know what, we live in the same community, the same society. We should care, and we care enough about measures like school readiness that we're prepared to put our money where our mouths are and where our values are. And that's where things like school readiness are so key. I hope that at some point, if we actually have a statewide measure of school readiness, that it could become part and parcel of how we pay Medicaid managed care plans. That it could become a key milestone metric that's used to assess the effectiveness of our healthcare system relative to the needs of young children. That to me would be a major step forward and would be showing a real desire by the healthcare system in New York State to embrace these measures that are not traditional healthcare measures.
So that gets to one of the other questions that we got asked, which is, can you talk about how we'll know, how will we know that this process has been successful? What are our either incremental or longer term measures to say that this has been something more than, a list of 10 good ideas?
Sure. So I think what we're going to do, and for each of the 10, first and foremost, I think it's important for us to demonstrate that we can coalesce around a 10-point agenda and actually implement that agenda. So, and it may sound like a simple thing, but there have been plenty of task forces over the years designed to address these issues, and they've come and they've gone. And I think what we're hoping for out of this is that the first 10 things, which we will track and we will report back to this group on how we're doing relative to those, they each will have their specific performance metrics. We will be moving forward and tracking and publishing all of those results from that. But the 10-point agenda isn't in and of itself a full comprehensive solution to the challenges that children and families face during those first 1,000 days. But we thought it was important to have a good starting point with initiatives that were evidence-based, where we could show, hopefully, improvements, moving the needle, so to speak, in terms of key outcome measures. But then to build off of that, and perhaps also as a next step for this group, is I think if we are successful in this first stage, thinking maybe a little bit bigger, thinking a little bit more about what are the measures that we want to achieve, the outcomes and such. And perhaps then that can coalesce around maybe a more aggressive budgetary ask in the months and years to come. I think at the end of the day, and I see sometimes that critique, I would say, of some of the efforts around requests for increased funding, is that it's just requests for funding, but it's not actually linked to a tangible, measurable outcome. I think an exception to that was the district program, where the federal government said to New York State, okay, we're going to invest, right, $6 billion into your system, but we want something for it. And we're going to link that investment directly to measurable outcomes. And at its core, what they were saying was they wanted a 25% reduction in avoidable hospital use over a 5-year period. Now, they also wanted improvement in a whole series of other metrics. If we aren't successful, we don't get paid. It's that simple. And so as a result, I think that it became that's maybe a powerful model that could be replicated here in some of these other cross-sector areas. And I think that it's an idea that I think in the health and human services world, I think we need to embrace, because sometimes we go off to our state legislatures or we go to Congress and we ask for a whole lot of money, but we don't necessarily say in exchange for this money, here are the measurable improvements you're going to get. We may point to old research, we may point to say this is the right good thing to do, but are we really prepared to, put ourselves on the line for success?
So it sounds like you're talking about that's one of the roles for the group when this same group and maybe growing comes back together, is to sort of say, okay, what are the measures of success? What are the ultimate measures? And then backing up sometimes, what are the process measures? And then moving forward with trying to measure those.
Yes. I mean, I think would be an interesting thing to do is if we actually, first and foremost, we don't really know how many children are in the school system developmentally behind where they should be. But if we did, then what we could potentially do is say, what would an investment of $500 million a year over 5 years in the following ways, what do we actually think we could do with that money to actually measurably improve that essentially important outcome? And then we could say, if we could actually, I think we could go through a process and work with outside experts to sort of put together a comprehensive strategy to spend that kind of money. But then would we be willing to say, okay, the money that's going out, the organizations who are going to receive this, who are going to implement these initiatives, are they willing to be held accountable? Accountable to the point where the money they receive is actually linked to the outcome. It's not just some grant program where people go off and do some nice things. I think at the end of the day, we should move away from that model. And in fact, I've said repeatedly that I think advocacy organizations should no longer be asking just for more money for programs. They should be demanding that people like me generate better outcomes for the people that they care about. Because at the end of the day, a well-funded, poorly run government program doesning do anybody any good. And really, at the end of the day, is what we should be really focused on measurable outcomes. And that's why I think our coalescing around a recommendation for how do we get to a universal measure of school readiness in our state is such a powerful one. So who are the other agencies that you think for something like that, for a universal measure of school readiness? Who else do we all together need to make sure is at the table? Absolutely. I mean, you need all the agencies that you had mentioned. And I think sometimes what happens is that in school readiness, we can focus too much on cognitive development. We don't focus enough effort on social emotional development. We need to look at the child comprehensively. All those aspects of development are key and essential and need to be part of the process. I mean, I think we've, throughout the past several months, heard anything from our diverse stakeholders. One of the things we heard very loud and clear was that. So I think we do need a diverse set of people to come together and coalesce. Sure, we should look at what other states are doing, but I think we have to be careful not to have it be purely an academic exercise in this pure sense of the word academic, in the sense we're looking purely at the cognitive abilities of the child. We need to look at the social emotional. Many of these children are growing up in homes in which they are exposed to violence. Many of these children are suffering the consequences of, in essence, a childhood form of post-traumatic stress disorder. And that has lifelong impact. It actually affects how the brain itself develops chemically. And so we need to acknowledge that, identify those things, and begin to think about what we can do to address those issues, both from prevention as well as from a remediation standpoint. So I've been involved with some of the work that Medicaid's been doing around the social determinants of health, and you mentioned earlier the social determinants. And we did talk a lot in this work group about the important role. In fact, we just created a whole bureau dedicated to social determinants. We have a question about that. So can you just talk a little bit about the social determinants and your interest in trying to address them? Sure. So we've been big believers in the need to address social determinants of health in Medicaid, dating back to the beginning of Medicaid redesign. In fact, up until last year or so, I thought there was a pretty much national consensus that Medicaid programs across the country needed to figure out ways to address them either directly or in collaboration with other sectors if they were actually going to be successful at achieving healthcare objectives, considering how social determinants of health are often the #1 driver of outcomes, healthcare outcomes for Medicaid members. And so we've done a number of good and innovative things, things like our supportive housing program, which has really been a national model. We spend almost $100 million a year paying rent or providing services, or in some cases capital grants to develop housing for high needs Medicaid members. And many great success stories have come out of that. But now we said is really what we needed, and also coming out of VBP, our value-based payment discussions. We are the only state in the country that has requirements that in the more advanced VBP arrangements, you must identify social determinant of health, and you must contract with a community-based organization to support you in that effort. But that said, we thought there was really a need across the Medicaid program to have a more comprehensive approach and to think more holistically around what we can do to more effectively address social determinants. And that's why we decided to basically bring resources from across the Office of Health Insurance Program together into one place and task them with developing a comprehensive strategy. So that unit will help lead our efforts in value-based payment. They'll play a key role in a lot of the work that we're doing in the first 1,000 days, particularly as we move into the implementation phase. But we also want to look at other things. I know one of the areas of people have raised as an interest is risk adjustment, which we do for managed care organizations, the possibility of including data about individuals and their social determinant health needs, like things like housing status, into how we risk adjust, which could shift millions, tens of millions, maybe even hundreds of millions around between plans to focus dollars and resources on those who have the greatest challenges from a social determinant of health need. So that is one area that we're going to task that group to look at as well.
That came up a lot during those conversations. Yep. That's fantastic. That's very exciting. Wow. Thank you. Thank you. So we've had a couple of questions about the first 1,000 days work and going forward, and to what extent it addressed the needs of kids who are fragile or have special healthcare needs.
Sure. So what we set up front was for this first 10-point plan, what we really wanted to do was focus on sort of the broader population of children and come up with an agenda that sort of address the needs of that broader population. But we're fully aware that we've got a subset of our Medicaid population who are children who are very fragile with very complex needs. And what I think we will also want to do in this next phase is to think about what we can do to improve care and outcomes for that population as well. We have some important initiatives going on in that space already, particularly the move to managed care for the foster care children, the recent launch of health homes for those children, which was actually quite successful with very high take-up rate for those children, so a new, more coordinated, more higher touch care management approach for those children. So there are some things already going on, but there's always greater opportunities. And I think we want to, particularly in the new year, engage that particular subset of stakeholders and think about what more can be done. I actually think there are some greater opportunities for VBP. You mentioned up front, one of the challenges with most children is that they don't cost the system a lot of money today. So traditionally, VBP is about generating shared savings in the immediate term because you're trying to get better outcomes, get lower costs. As a result, and that does not work as well with your sort of average child who generally has relatively low healthcare costs. That said, with the more complex, particularly medically complex, as well as behavioral complex children, there actually are some real opportunities for shared savings, and we think we want to explore that more with the group as well.
Great, great. So we have a question about the communities that might qualify for the home visiting. So we had a maternal infant, early childhood home visiting recommendation, and how the communities, we said 2 to 3 communities that have some high risk factors. What do you anticipate will be the process for identifying and selecting those communities? So
that's a good question. I think that's one of the things that we now take back as a work product on our end is for each of these recommendations. And this is also one that has budgetary implications. We have to sort of wait and see how the budget works itself out and see how much funding is available. And we're back.
You know, we lost the feed for a minute. Don't worry, you didn't miss anything.
So I was just saying was that we were talking about the particularly for home visiting and the pilot programs and which communities would be selected. So there's a lot of details that need to be worked out, and I think before we go out with the solicitation to sort of see who's interested, I think we will want to put out more information for public comment to try to get a sense. We'll have to wait and see what the budget does and see how much funding is available come April. But the one thing that we are definitely wanting to encourage is these cross-sector collaborations. So any community that's really interested in applying, if you don't yet have a home visiting program today, but you'd like to launch one, what we would encourage you to do is to do a self-inventory in terms of are there any cross-sector collaboration efforts going on in your community. If not, I think you want to start dialogue and discussion around creating one. I think it's good in the best interest of your community no matter what. But I think that's going to be one of the key criteria that's going to be used for determining which communities get these funds.
So that's something I think that, I know that in advance of this event, a lot of folks were asking me those kinds of questions. So for folks who are thinking about, it sounds like the home visiting and some of the other initiatives that you're thinking about and trying to figure out what can happen locally, I think that the important message for folks to hear is to be thinking about what's already happening locally, what tables exist, and trying to leverage those.
Yeah, absolutely. I mean, I think at the end of the day, it's great that we're working towards collaboration at a statewide level. Mm-hmm. You know, getting these big organizations, institutions, whether it's SED or the SUNY system and the Medicaid program and state government more generally, working together. The collaboration that, frankly, is going to make the biggest difference in the lives of young children is the collaboration that happens in Utica and happens in Lake Placid and happens in the Bronx and happens in communities all across our state. And I think that there are a number of efforts that are going on, and so we want those efforts to hopefully see this as an opportunity to re-energize their efforts, to know that there's, at the state level, there's increased interest in their activity. But in those communities, if you're in one of those communities that doesn't yet have that, my strong recommendation to you is that you use this as an opportunity to get your stakeholders to coalesce together. Chances are you know in your community who you need to invite to the table, and prepared for the possibility that there'll be some funding opportunities coming from the state. But in order to get into those opportunities, you're going to need to have these local collaborations.
Yeah, I think at the work groups we had a lot of that conversation about thinking about how can the state be an enabler of potential successful collaborations at the local level.
And that is one of the things we're also thinking about too. Is that what does the state have a formalized role in supporting them? Mm-hmm. Do we just inspire them and make some of our grant awards dependent on those? But I think that we just feel very strongly that there's a real benefit to the community that unless you're thinking cross-sector, unless you are collaborating in deep and meaningful ways, any one of these programs, new initiatives, is not going to make a difference, because ultimately at the end of the day, what needs to happen is that you not only need to do new things, but you have to assess the impacts, for good or ill, of the programs that already exist in your community and figure out what you can collectively do to improve them. And I think that one of the things we've learned through the Albany Promise process was we did a detailed process map that laid out how a child is identified as having a developmental issue and how they are referred for service and how they ultimately get service. And when we laid that out, we realized just how complex that system is. And it showed very clearly why it so often happens that families fall through the cracks and they don't get all the way to the service that ultimately they need. And there are things that can and need to happen within that existing process, mm-hmm. that can meaningfully improve outcomes for kids that aren't going to cost a penny, but are just require us as organizations and communities across the state to actually change how we adults act and how the programs that we run operate. And I think that we want to encourage that kind of discussion in communities in every corner of the world.
Thank you. We have a question about mothers being assessed for postpartum depression, since that can play such a large
Absolutely.
role. So can you talk about that specifically, but also sort of that the work group's sense of the role that caregivers play in a child's healthy development?
Absolutely, and I think that as we've said, and there's been a lot of focus on assessing developmental status of children. We also need to think children are not growing up in a vacuum. They're growing up in a household. They're growing up in a family. They're growing up with caregivers, and the social emotional status of their caregivers plays a huge role on their development as a child. And so it really is important for us to think holistically around the whole family and not the child. One of the ideas that was discussed, and I think is worth some further discussion, is could we identify eventually some high needs, high risk families? Because sometimes the issue is that if you simply focus all your efforts on children, you miss the needs of the parents, you're going to have limited success in terms of this. So much of a child's time is in their first few years of life is spent with their parents or their caregiver. And so I think what we're very interested in is new and interesting ways to think about those families. And frankly, maybe even applying the value-based payment lens to them in some way might be an interesting idea for us to explore in the future.
Yeah, I know I've heard from folks too who are very interested in thinking through how do we approach value-based payment with the understanding that, that the parents play such an important role. Parents or caregivers play such an important role in a child's life, and if we can help improve the parents' and caregivers' health, we are likely to improve the child.
Sure, and I think one of the interesting proposals that came out was this idea about grading funding. Is that I think that, and it was also an issue that one of our VBP work groups was challenged by, which is that a lot of times that you can make an investment in one sector that generates savings and better outcomes for another sector, but rarely is there an opportunity for these sectors to share resources across these funding sources. And so I think that one of the things that we need to think about, and this is where maybe within communities even, they can think is how could we look for ways to share resources across these sort of traditional boundaries. And I'm very interested in places not only across the United States who are doing this, but also around the world. There's a lot of interest in cross-sector collaborations. I think one of the most interesting places for us to watch now is Manchester, England, where they have, through devolution, merged authority for multiple sectors into the Greater Manchester Authority, and they have a newly elected mayor, Andy Byrne, and they are thinking about what they can do with an investment in the criminal justice system that could generate savings in their healthcare system, or a healthcare investment that could generate benefits and savings in a social care environment, and vice versa. And I think it's very, very interesting to watch because it potentially opens up, when you can figure out ways to grade the funding, it opens up a whole new set of solutions that people may not have thought possible or worth considering in the past.
That's great. You know, I got this beautiful big note from our staff saying we're hearing from a lot of people how excited they are to hear Medicaid thinking beyond medical. So that seems to be sort of one of the overriding themes that we're hearing. So that is a perfect sort of way to close. So can you just, before we close, talk a little bit about what you think are the next things that are going to happen with regard to the first 1,000 days?
Sure. So first and foremost, we've got some work on our end to do to start thinking about, of those, particularly the 10 items that are non-budgetary, we're going to move full speed ahead in terms of beginning the process of implementing those. So we're in the process of developing work plans and starting to think about how we can really begin to implement those things at the beginning of next year. The budgetary items are up for discussion. We're in the final stages of developing the governor's proposed budget, so hopefully we'll see how that plays itself out, but hopefully we'll have some funding opportunities in that budget, but obviously the legislature will have its say. But hopefully, and I encourage folks who are watching today that whatever gets in the governor's budget to advocate with our legislative colleagues for why it should stay there. It's going to be a tight budget environment, so that's always a challenge, but all new investments will, as they should be, closely scrutinized by the legislature. but encourage that advocacy role. But whatever does come through the budget process in April, then we'll want to move forward implementation there. I think also in all of the group, we will be providing them regular updates at meetings, discussions around our implementation of both of the sort of buckets of initiatives. But then I think we're also taking a step back. I want to think and work with UK and the other chairs is to think about what is our next big step. I think there's a lot of interest with fragile children around a specific set of projects around them. But how do we want to hopefully further build, and then maintain the momentum? And I think we're going to be obviously interested in all working with SED on their recommendations and such. But I think that's going to be the next key question for us: is what's the next big thing? I suggested today a few things, but I think we'll want to work with all of you on what those next things should be.
Thank you. So we'll be keeping folks in touch. Or keeping in touch with you all, and please go to our website if you'd like to join our mailing list, because we will be kind of from the outside reminding you about those budget items and the timing on making sure that you make your voices heard so that these things move forward. And we are right now scheduling another Facebook Live conversation with State Education Commissioner Mary Ellen Elia, who will talk a bit about her role in the first 1,000 days, but also the Regent's Blue Ribbon Committee on Early Childhood Education, because we think there's some great alignment there. And then following the Governor's State of the State, a few days later, in January 9th, the Schuyler Center will be hosting the State of New York's Children event. So please check out our website to learn more about that. Thank you for joining us for our first Facebook Live event, and we hope to see you again.